all of you for coming because you make this the successful program that it is. My name is Jim Garrity. I'm at Mayo Clinic in Rochester, Minnesota, and I see all the eye problems in Wegener's. And according to some of the research that Dr. Abdou collected from members of this group, and we've got a poster outside the room here, I expect to see about 1/3 of patients with Wegener's in the eye department. From my standpoint, vasculitic involvement from Wegener's or any other type of vasculitis is so nonspecific that when someone comes in, I always entertain a big list of possibilities regarding, well, what else could this be besides Wegener's? For folks with a new diagnosis of Wegener's, the inflammation usually affects 3 areas around the eye. The first and most frequent would be the eye socket itself. And one of the reasons that the eye socket is involved because it's right next to the sinuses. So Dr. Lebovics and I have become very good friends through the years, sharing difficult problems in that regard. Inflammation of the eye socket or orbital pseudotumor is very nonspecific, and when it shows up on a CT or an MRI, if it's amenable to biopsy, I always push for a biopsy because, as I mentioned, it can be something else. It can be lymphoma. It can be a fungus. Some of these unusual things. So in essence, Wegener's becomes a diagnosis of exclusion. So we always try and biopsy things if we can. Other areas that are involved are the sclera. The sclera is the white coat of the eyeball. And when that gets inflamed, that's sight-threatening. It's also extremely painful. And involvement of the sclera almost demands treatment with either prednisone, Cytoxan, or Rituxan. The other area that can be involved is the cornea. That's also quite painful and sight-threatening. As I mentioned, if there's something amenable to biopsy, I will push to biopsy to establish a vasculitic basis. For folks that have been on immunosuppression for a long time, biopsy becomes important to exclude other conditions like lymphoma, because patients who have been on immunosuppressant medication for a long time can be susceptible to developing a lymphoma. Additionally, a fungus can show up in the setting of an immunosuppressed patient. So from my standpoint, biopsy becomes important. The other thing that I just wanted to mention was a red eye. And we've got a poster out here on a red eye. And the title on it is, Should I Be Concerned? There are many reasons for a red eye. One of them is the medications that you take. Aspirin, prednisone, perhaps Coumadin. And if you cough or sneeze or do something like that, you'll get a blood spot or a hemorrhage on your eye. And that's the eyeball equivalent of a black and blue mark on the skin. Other causes of a red eye can be a scleritis or an episcleritis. And as I mentioned earlier, the scleritis would demand some sort of systemic therapy. A conjunctivitis is just a routine pink eye, and that would just need a drop of some sort or another. And then the last thing that I wanted to end with was when the Wegener's is adequately treated and under adequate control, sometimes patients will come in with tearing. And either Dr. Lebovics from the ENT or us from the ophthalmology can do some surgery to make a new tear duct to get rid of the tearing. And I know that gets to be a big quality of life issue for some folks with adequately treated Wegener's. But that's a capsule summary of ophthalmology, at least from my standpoint, and I'll try and get some of these questions in just a moment.
I'm Paul Monarch from Boston University. The questions keep pouring in, and they're good ones. I've been up here a couple of times already, and I've already accumulated a stack of questions I haven't answered yet, and I want to. The overall theme that I see is related to the questions that I'm getting here, related to treatment. And there's some general broad themes that I want to cover now, and then also want to try to get to every specific question if possible. So one question that obviously has occurred to a lot of different people has to do with maintenance therapy. And I think the questions come down to when, which drug, and how long. And the answers are not scientifically there for those questions. The closest we come to it is for the first question, when. I think for patients with severe disease that, meaning when you switch from cyclophosphamide to a drug like methotrexate or azathioprine. And there have been a number of studies now that have used the strategy of doing that somewhere between 3 and 6 months. Usually people say when the patient is clinically in remission, which is not always trivial to figure out, but when you can, then that's an okay time to switch, at the same time as prednisone is being reduced. Which drug? The French group recently showed that azathioprine and methotrexate are basically equivalent in terms of tolerability and effectiveness for remission. So I can tell you what I do, and that's similar to what some of my colleagues I work with do, is which in a patient who's had severe renal disease, we usually use azathioprine. And the reason is not that it's more effective, but the methotrexate actually is cleared out of the body through the kidney, so we worry about it building up to toxic levels in patients who have renal problems. You can still be careful and do it if you have to, but that's usually our first choice. And if given a choice, I usually use methotrexate for patients who have a lot of upper airway disease, because there is the clinical trial basis from the NIH, Drs. Langford and Hoffman and others who've used it for remission induction in the first place. But either drug works. Mycophenolate, we're waiting for the data to actually come out, but the word is that that's really should remain the third choice. We were hoping it would be a more effective drug, and the suggestion is that for the purpose of maintenance, which means either low dose prednisone at the same time or nothing, it's probably, if anything, not as good. So I use that in patients even the other drugs are not working or not well tolerated. The question of how long is the hardest one of all really has no good answer. What I think we have gotten in the habit of doing with our multi-center group is to treat everyone for 18 months, and if you're in remission of 18 months, then you slowly withdraw the medication. And at that point, if the patient flares thereafter, then you put them back on a maintenance drug, and you have, for the most part, say you're probably stuck with this for life. Of course, that becomes that is not necessarily going to be true for everyone. That's negotiable. There's always there's always a discussion with the patient about that. But that's the usual policy that we follow. Treat for 18 months. If at that point you can come off the drugs, a third of people will not have a relapse. 2/3 will. They have no way of knowing who is who, with the exception that patients with Wegeners are a little more likely to flare than patients, and I think that's everybody here, rather than patients with microscopic polyangiitis. But that's really about it, and there are no blood tests that tell us what the course will be. So that's why I think I can quote Carol Langford accurately by saying, she says, everybody deserves a chance off of the medications. Now, of course, I also sometimes have patients who've had a really bad time first time around, and they don't want to come off the things. So I'm willing to take azathioprine the rest of my life if it reduces the chance I'll never have it again. I think that's okay. These are discussions we have.
I guess we pass the questions as we go by. Everybody will take 1 or 2 questions, and to be not boring. I have a question here about what is considered normal level of ANCA. The normal level of ANCA, what the lab determines. And the lab determines getting like 100 normal healthy people and do ANCA on them, and that is the normal range. So it varies from lab to lab. The normal lab now in our area is 1/20. That's the dilution of the serum of the patient. 1 to 20 is a negative test. Anything above that, and we have seen patients go to 640, 1280, very high levels. And there is a trial now to convert that dilution ratio into nanogram quantities of the antibodies. This is not commercially available yet, but I hope will be available. That will be a more accurate test for anti-neutrophil cytoplasmic antibody. I have another question here. I don't know how to describe it. Critical question. What is the best you could come up with as if we didn't have a enough problems explaining disease to people. And there is a sad face below that. I don't know how to answer that. Maybe some of my colleagues here. What's the best you could come up with if you didn't have enough problem explaining disease? I really don't have a good answer to that. I think I found that education is very important and learning coping skills, and there are 2 or 3 sessions this meeting about coping skills, and that is needed to understand the disease. I think get the newsletter from the Wegeners, get yourself educated, ask critical questions to your physician to let you know clearly what stage is your disease is, what you expect and not expect, and that will help a lot to improve your knowledge about the disease. Do you have a question?
Just let me echo Dr. Abdou's point there before I get to what I have here. I think to answer that question, it's a partnership. It's not like, here I am, educate me, do everything, provide me with, an 8-course meal here. It doesn't work that way. The very fact that you are here shows that you're taking the initiative, time, money, initiative to learn, because you have to be a part of your solution. Trust me, doctors don't know everything, and I've learned things from my patients, I've taken suggestions from them, and little nuances make a difference. So think of it as a partnership, and more importantly, you learn and you have to contribute to each and every one of you. I would encourage that tremendously. In terms of questions here, I have one. Is frequent aspiration of saliva or foodstuff an indication of Wegener's issues? The answer is generally not. Aspiration, by definition, is any type of particle going down the throat and going into the wrong pipe. In other words, when we swallow, it's got to go into our food pipe, that's how we're built. If it goes into the windpipe, that's bad. On a simple level, we all do aspirate a little bit of fluid, and that's okay. A little saliva goes down, we have mechanisms to clear that from our lungs. It's called the ciliary transport system. But and as long as you don't become sick from it, I usually say it's not an issue. But aspiration in and of itself is generally not associated with Wegener's or any of the vasculitis which I'm aware of. Another question here is someone who's developed burning on facial skin, and it's continuous, and there's no redness. Could there be a relationship to Wegener's granulomatosis? Cutaneous vasculitis or skin manifestations of Wegener's clearly does exist. It's not common, but it does. Probably one of the greatest doctors who ever lived was Virchow. In the 19th century, he defined his 4 features of inflammation. One of them is here. In Latin, it's calor, dolor, tumor, rubor, right? Swelling, heat, pain, and rubor, and redness. And function. Well, and so you're saying here, is this, and Wegener's is an inflammatory disease. There's no redness, the burning. It's probably not a classic form of inflammation. It sounds to me in this case it's probably more neuropathic. I'm an old-fashioned guy that at the end of the day I can say what I want and think what I want. But you can quote me on this, tissue is king. One bad pathologist is worth more than all of us up here on the table here. When in doubt, especially a skin lesion, it's okay to biopsy it. It's not a simple thing to biopsy a lung, so then you have to be more circumspect. But a little skin lesion to take a punch biopsy and send to the lab information is just critical, and it's very, very helpful, and I just don't know how to emphasize that. Last one.
I also wanted to make some comments regarding the unhappy face question that came in. And I think that loss of your health invokes a grief reaction. And you have to move through each phase of a grief reaction. There's anger, denial, bargaining, depression. And I think anger is just a type of depression. And then we finally move on to acceptance. And I think that one of the big functions of this group is to help people move through the grief reaction. And I think that you're here today because it is at an acceptance level. It says, okay, this is what I have, what are we going to do about it? And so a big pat on the back to all of you for being here. A couple eye questions. One of them is there's a diagnosis of necrotizing scleritis. What treatment is done to retard it, and how much, and how to treat it? Scleritis comes in various flavors. And at one end of the spectrum, there's a simple diffuse scleritis, which all scleritis to a degree is sight-threatening. But the one that would be the least sight-threatening would be this simple or diffuse type of scleritis. As you go to the other end of the spectrum, you get to necrotizing scleritis, which, frankly, bothers me the most. That one is sight-threatening because untreated, it will lead to perforation of the globe, and you will lose your sight. You'll lose your eye, too. So when we see necrotizing scleritis, the first phone call I make is to Ulrich and tell him what we have and what we need. From our standpoint, we need systemic treatment. We need either high-dose prednisone, probably Cytoxan along with it, and more recently now, Rituxan. So we have had some folks with difficult to treat necrotizing scleritis who have sustained all of the side effects that you well know with prednisone, who we've moved on to Rituxan. Rituxan has worked very well with some of these bad scleritis cases. One of my old professors called scleritis the red, white, and blue disease. It's white when it's normal, it's red when it's actively inflamed, and then it's blue when it's all healed. And what happens is the scleritis thins the sclera so that you see the inner coat of the eye through it, and that's the blue spot. So you can just look across the room, and if anybody's had a bad case of scleritis, there'll be a blue patch where it used to be. But in the necrotizing scleritis, if it gets too thin and the globe is at risk of perforation, a cornea specialist is who would do this. But a cornea specialist would do what's called a scleral patch graft. So donor sclera would be used to just cover up the hole or the thin area. Sometimes if you don't have sclera, you can use bovine pericardium, you can use fascia lata from the leg, you can use temporalis fascia from this muscle right here. There are all sorts of substitutes that are available. But necrotizing scleritis demands intensive therapy, and it might also involve some of this reconstructive surgery that would be done by a cornea specialist. There's an easy question in here. Someone was diagnosed as having MAP fingerprint print dystrophy of their cornea. Is it related to the Wegeners? The answer is no. There are 5 layers to the cornea. This MAP fingerprint dystrophy is a problem with the very superficial layer, and sometimes that layer sloughs and forms a little rough spot, so it feels like a corneal abrasion. But that's not at all related to either the therapy or to the disease. The part B and C of this question is, I also have cataracts and dry eye. That's not a complication of Wegener's per se, but rather that would be a complication of the therapy. And prednisone is a wonderful drug, but it has a whole host of side effects. Glaucoma can be one of them, and cataracts will be one of them. It's said that if you take 10 milligrams of prednisone daily for a year, you'll end up with a cataract. It's probably true. But you know, a cataract is something that can be treated quite readily. So it's an unfortunate complication of the drug, but it's one that can be handled quite easily. The dry eye can be also a therapy-related complication. Fortunately, there are a lot of good artificial tears on the market. That's one thing. Sometimes we can put a stitch in the eyelid to reduce the amount of exposed surface area. We can do that. Sometimes we can put moisture chambers on glasses, which help quite a bit. But there was an article that came out 2 years ago comparing quality of life with severe dry eyes. And the quality of life in someone who had severe dry eyes was equivalent to someone on hemodialysis. So dry eyes really are nothing to push off to the side, because it really can affect your quality of life. But there are some options that are available, and we can go over those further in the eye session next, if you wish.
think I'll take 4 questions if you don't mind. I think I have a big stack, and I really do want to answer people's questions. And for me personally, anyway, if I don't get to your question, you can try to grab me at any time for the rest of this meeting. First is methotrexate ever used with rituximab? So it has not been reported in this disease, but it is actually widely used in rheumatoid arthritis. That's one of the standard ways that it is used. So we have some safety data on the combination of the two in a different disease. So there is always the possibility that Wegener's patients would be at higher risk of infections by combining these 2 drugs. But at least we're not completely shooting in the dark in that regard. I have not yet been in a position of having a patient whom I treated with rituximab and they got mostly better but not quite, and whom I wanted to use both, but I expect to sometime in the next year or 2 in order to say get the dose of prednisone a lot lower. It isn't something we routinely advocate, but it is the kind of reasonable improvisation that you might do for a particular patient. Another question I have is, should patients with asthma take methotrexate as a maintenance therapy for Wegener's? And the answer is there's not a reason not to. Some pulmonologists, Dr. Speck is, I would say definitely not one of them, are leery of using methotrexate in patients with lung diseases because it can cause a hypersensitivity reaction, a fairly severe allergic reaction in the lung. And I think even more rarely than that can cause a pulmonary fibrosis or scar tissue in the lung over time. On the other hand, the methotrexate isn't used to treat asthma. We don't really use the same kind of drugs we use in rheumatology, but a lot of people wondered if maybe they would work. And if I remember correctly, there's even been a randomized trial where for patients with severe asthma, methotrexate was used and shown to reduce the amount of prednisone patients needed. So there's not a reason not to use it, and it may even be a little bit helpful for the asthma. That's, of course, assuming that you didn't have a severe allergic reaction to the methotrexate. Another one I have is, can a Wegener's patient be placed on Coumadin because of who has been placed on Coumadin for DVT ever come off it? And I can say confidently we don't know the answer to this question. So Wegener's is associated with a high rate of blood clot formation, particularly in the veins of the legs, but also traveling to the lung, which is called pulmonary embolism. It is a dangerous condition. And so anyone who has what's called a deep vein thrombosis, DVT, is anticoagulated for some period of time. I don't know if the standard now is 6 months. But in general, certain people who are thought to be particularly high risk are left on it lifelong, and others are not. No one knows where Wegener's patients stand with regard to that. And the reason is that in the studies where this was shown, which was led by Peter Merkel, the patients who had highly active disease were the ones at the highest risk of having DVT. So we would like to think that if the patient is in remission, then they could come off of the Coumadin, but I can't promise that. And in fact, we did have a patient who had a recurrent pulmonary embolism. He did fine, but now he's stuck with it lifelong. So it's an excellent question.
Can we move Paul?
We try to move around so we don't get bored. And I see some of you have closed eyes now, Nabih. So what should we do about that? We cannot dance or joke here. So wake up, please. Maybe stand up for 1 minute. Stand up. I have a question here that says, most speakers have stressed monitoring patients with ANCA-associated vasculitis. What should we monitor? When we have a big question like that, I learned from my mentor, the best answer, it depends. So it depends what part of your body is affected by Wegener's. And let me tell you examples. My patients who have chronic sinusitis, and I'm gonna probably jump on my neighbor here, what should we do with sinusitis? I think it's a must. Every patient with sinusitis from Wegener should learn how to sinus rinses. Every day, every day, every day. The question, should you use a nasal steroid or not, is open. It's not really definite yet. If you have a kidney disease, all my patients, it's a must. If you have a kidney disease, you should do 2 things. A, buy dipstick and test your urine at least once a week. And if you see change in the protein or sugar or blood, you need to call your physician. This is very cheap. It's about 6 cents a dip that you can do. Number 2, if you have a kidney disease with hypertension, invest $35 to buy a sphygmomanometer, blood pressure machine, and learn how to do your blood pressure at home. I learned that from my mentor. Unless you leave the room with some practical issues, you wasted your time. And the practical issues I'm going to give you today, if you have sinus problem, you need to do sinus rinses. I'm not sure nasal mist is important, but I'll leave that to my ENT colleague here. If you have high blood pressure, you need to get a blood pressure machine and monitor your blood pressure. And if it goes high, you need to call your primary care or specialist. What should I do? Cut down your salt intake. Number 3, you are on aggressive treatment, chemotherapy, immunosuppressive drugs. I think you have to be up to date on your immunizations. And please don't take the vaccine the day you take rituximab or Cytoxin. You're not going to get a benefit because these drugs suppresses the immune system. I've seen that mistake done a lot. Try to space that. The day you take IV Cytoxin or rituximab, don't take your vaccine. Space it like a week or 2 before or after. This is important, simple things to do. Learn about your disease. Number 4 is you need to have good communication with your primary care physicians. They are at a loss, I have to tell you. Many primary care physicians don't know much about Wegener's. So you need the doctor so-and-so. I read this interesting article. Will you please take it and home and read it? Educate your doctor. And if you have a stubborn primary care physician, change the physician. Or ask your specialist to be your primary or help you with finding a one that understands your disease. So you need to be proactive with that. I have here a question. What is the standard dose of methotrexate therapy prescribed for Wegener patient during remission status? There is no really good answer for this. How much methotrexate? It depends. If the disease is in remission for 6 months or so, probably you don't need methotrexate. And your ANCA is very low and you're feeling good, no organ damage, you don't need to take that. There's many other things you can use. So it depends. There's no guidelines. Every patient is different and the recipe have to be tailored to the patient. If there's signs of disease activity, again, we have to use methotrexate or the others, depending on the case. The average dose is usually about 15 to 20 milligrams a week. Some patients require more, some require less, depending on the liver, kidney, and the blood counts. In general, another question. In general, what is the prognosis for a Wegener's patient in remission who has 50% kidney function? These are difficult questions. I hate to generalize the answer. Again, it depends how long you have the kidney damage. What kind of kidney damage? Do you have associated problem that could increase the damage, high blood pressure, kidney infection, and so on? All that will compromise your kidney. So there's really no good answer to that. But in general, I think if the kidney is stable for 6 months to a year and the disease is stable, I think we relax a bit. And depending on your physician or specialist, what they're going to tell you. I have a question here. When you talk about active disease versus damage, you said there is nothing to be done about the damage. Is there any research going on with regard to the different types of damage to the sinuses, lung, kidneys, and muscles? It's a huge question. I think the question is the damage, is it reversible or not reversible? Could be reversed. And I think in many patients, after aggressive treatment for a while could be weeks, months, or years, we say that's all we can do. We can add more damage if we treat the patient aggressively. Then we maintain what is left and live with that, adjust to that. So this is a difficult question to answer, and the best answer, it depends on the patient too, and adjust the dose of the treatment or the lifestyle depending on the degree of damage. If you have a major kidney damage, that's a bad prognosis, and you need to think about renal transplant. And if you do renal transplant, have renal transplant, I've seen really disaster being done in a hurry when the disease is active. The disease, in my judgment, should be inactive, stable for at least 6 months before any renal transplant to be done. I have a question here. Most speakers have stressed monitoring patients with ANCA-associated vasculitis. What should we monitor? And I have another question. What triggers a change in treatment? What triggers a change in the treatment is disease activity. I've seen that. Wegener is a very, very tricky disease. Even if the disease is remission, I ask the patient to see me at least every 3 to 6 months, even if things are stable. There are many factors that we don't understand yet. Things are quiet for years, and the disease gets activated, which we don't understand yet. So I ask my patient who are in remission to see me at least once every 6 months. And more important, I educate them what to look for. If you have streaks of blood in your sputum, if you have increased sinus drainage, if you have decreased hearing, if you have vasculitis rash, if you notice the color of urine is changing, or the volume is changing, or if you have extreme fatigue, not usual, if you start having joint problem, or you start having rash, reddish rash, not itchy, and not painful, just rash, you need to let me know right away. So it depends on the case to, I'm going to move on here.
So just to follow up on that topic that Dr. Abdou mentioned about the nose and the paranasal sinuses, particularly diseases like Wegener's and Church-Strauss, you have to differentiate active disease, or where the disease is like the fire is burning versus now the fire is out and what you're dealing with the after effect damage. There is, in theory, therapy and hope for redemption or for some type of improvement in certain cases that we just talked about, reconstructing the outside. The other side of it is, if you're active, it's a joint effort between the rheumatologist and the otolaryngologist on how to quiet down that fire. The next point that I want to make, I think is a critical one, is when everyone says irrigate your nose, wash your nose. What does that mean? Right? I'm sure half of you have been told that at some point. A nurse I work with at NIH, I don't know if I'm allowed to recommend one particular book, but I'll take a chance. It's called The Nuances of Nasal Irrigation. I know financial interest in it, I assure you. It's everything you need to know about rinsing your nose. It's by Susan Rudy, she's a registered nurse. It tells you different instruments you can use, different water picks, different solutions, how you make it at home cheap, how much bicarbonate to put in there. Let me just say it's critical for people who have disease within a tract of inside tissue. The nose, sinuses going down to your throat. You need to cleanse it, because what the disease does is it breaks down the tissues that normally do cleanse it. So you have to compensate by doing it mechanically. It's a pain in the neck or a pain in the nose to do it, you gotta do it. I've heard Tony Fauci, spoken about reverently many times today, and I'll add my accolades in advance. I can't say enough nice things about him, wonderful things. I've heard him say at least half a dozen times in Wegener's patients that disease in the nose triggers the disease, and the disease triggers more sinus and sinonasal disease. You gotta break the cycle. The simplest, cheapest way, without complications, is regular nasal hygiene, nasal irrigation.
Got a couple interesting questions here. One of them is, have any of you seen a Wegener's patient with brain involvement? The answer is yes. They usually show up with severe headaches, but in the eye department, we also tend to see them because of double vision. And you can have double vision in Wegener's for a couple reasons. One of them is if you have inflammation within the eye socket, that causes a mechanical restriction. So in other words, you just can't look over to the right because there's a big lump that you can't move the eyeball against. You can also have involvement of an area called the cavernous sinus, which is where all the little nerves that run the eye muscles come through this area. The cavernous sinus is in the brain, and seen maybe half a dozen folks with cavernous sinus inflammation that have double vision, droopy lid, plus minus loss of vision. I've also seen brain involvement from people who have extensive involvement of their orbit or their eye socket, and it spills over into the intracranial cavity. It usually involves the meninges, not the brain itself. And an MRI is probably the best way to diagnose it, and when you see it, it needs either Cytoxan or rituximab to treat it. Here's another interesting question. Twice within the last year, I've had posterior scleritis confirmed by an ultrasound. Once my ANCA was positive, once the labs were normal. Can quiet Wegener still cause scleritis? Yes. And in fact, this patient who wrote this in says, I've been on methotrexate weekly and prednisone daily for 4.5 years. And remember, from my standpoint, I said that I like to biopsy things if there's anything that's amenable to a biopsy. We've seen folks with this inflammatory orbital pseudotumor progress while being maintained on prednisone and methotrexate. And when we've biopsied the orbital inflammation, the pathologist came back to us and said, there's an active vasculitis in here. So yes, while you might have quiet disease systemically, I don't think methotrexate and prednisone controls the ocular involvement from Wegener's. So the answer to your question, at least in my experience, has been yes, you can get a scleritis with quiet disease.
First question I have here is, at 4 months, I still have some slight joint pain and nasal drip. Does this mean Cytoxan is not adequate? So I can fortunately answer this as no, it doesn't mean that. And the first issue is, the degree of joint pain and nasal drip is different for every patient. It might even be from the prior damage, not permanent joint damage, but you can have aches and pains for other reasons. Certainly nasal drip from having had Wegener's. But even if we knew it was from Wegener's, this would not mean that the main drug is a failure and that you're going to do worse when you're switched from today's azathioprine or methotrexate. It's easier to control disease once it's partially or mostly controlled than it is to get it into remission in the first place. And from Dr. Speck's talk this morning, about 15%, I think even 20% of patients in the RAVE trial were clinically in remission, but and I think clinically in remission is still requiring some prednisone. And this is a sort of a case like that. Either with cyclophosphamide or rituximab, you start reducing the prednisone, and when you hit 10 milligrams or 5, some of the symptoms come back, and then maybe you make a decision with your doctor whether to go back on it. But that doesn't mean that the big drug didn't work and that other maintenance drugs aren't going to work for you. Next, very different and important question is, how successful or unsuccessful have you been at getting insurance companies to pay for rituximab? And the answer is very successful. I had just one case, I think Dr. Marco had any, where I really wasn't able to get approval initially, and then once the paper came out on the RAVE and Rituximab papers back-to-back in New England Journal, they turned it right around and reversed it and approved it. So I think now that it's in print, it will make a big difference. Insurance companies, even though you might think that they would limit things to things that are actually FDA approved, in general they don't. They have physician reviewers who look at the scientific evidence, and if good quality trials are published, they tend to recommend that these things be allowed. I have no idea actually on FDA approval itself for rituximab, but we certainly have experience in getting it in advance of it for patients. The last one I wanted to address quickly is, I'm approaching a 2-year rituximab anniversary. At what point does a physician determine to start another round of infusion? When things are quiet and I'm worried about a potential flare. And so this is one of the big unknown questions with rituximab. When should we retreat? We don't know yet from the RAVE trial whether patients tend to stay in remission longer after a single course than patients who are treated with conventional therapy. I will say that there are a lot of people who, this has been an issue mostly in the UK, of adopting standard practice of retreating every 6 months, and their experience has been that patients actually have a lower remission rate. We don't know if that is the strategy. We hope there's a trial from France that will answer that. But it's something we're confronting all the time, and it's something we sort of discuss with patients, the pros and cons.
I have a few questions here, rather important. The first one, currently I have no lung or kidney involvement. What kind of test should I have to monitor these areas? I think for the kidney, a blood test called serum creatinine and a urine test. This is if the kidney have normal function. If the kidney is not functioning well, I suggest every 6 months to a year, you should have a 24-hour urine collection for creatinine clearance, the function of the kidney, and the amount of protein. As I said earlier, if you have a kidney involvement, I suggest you buy dip sticks, very cheap, and monitor your urine test depending either once a week or once a month. And what other tests you need? I think once a year you need to have NCAL and PR3, especially PR3 test. And you need to have a folder for your medical condition. I love patients that come to the office with a table. This is my serum creatinine 10 years ago, and so on. It makes it easy for us. This is my urine analysis. This is my blood pressure. This is my blood count, and so on. This is your body. Monitor that. Keep track of it. This is your property, and take good care of it, so to speak. So I think that's how often you monitor. I think there is no good answer. If the disease is active, very active, probably I do it every few days or every very few weeks. If the disease is inactive, I say once or twice a year. So it depends. There is no good answer to general that. I have an interesting question here. How old is the oldest living patient with vasculitis? I don't know, but I have a patient who is 79 years old with Wegener's. I diagnosed 27, 29 years ago, and he is alive and well every time. He comes to the office, you know, Dr. Abdou, I won my hockey tournament. He plays ice hockey. He's 79. And so I have the youngest patient, I think. I diagnosed him with Wegener when he was 9 years old. And he is now 17 and doing well. And he has excellent family support. So there are extremes of ages that are affected with Wegener's. What suggestions do you have to reduce or prevent catching contagious illnesses while traveling? And he is asking any medication or any vitamins. I think catching or preventing contagious illnesses is direct contact, and it varies. There is no rule. If you are in chemotherapy, immunosuppressive drugs, I will be very careful. I found that the worst thing that could happen in terms of catching is hugging or kissing your grandchildren if they have an respiratory illness. I found it very common. The second commonest thing is the working with dirty material, not washing your hands. So develop the habit to wash your hands. And try direct contact, especially with young kids with respiratory infections. Or if you change diapers, you have the luxury or the privilege of doing that, wash your hands after you've changed the diapers of your grandchildren. Just simple, good hygiene. Currently, I have no lung or kidney involvement. What kind of test should I have to monitor these areas? How often? As I said earlier, I say if you are stable disease in remission, I say it depends, 6 months to a year, but should not forget, and you need to educate yourself. What should you look for early signs of disease activity? This is a long list which I mentioned earlier. I'm going to move in here to.
I have a question here on hearing. It goes, how do you treat fluid in my ear? I've had 3 myringotomies. Do I need tubes? So I'm assuming this is either a Wegener's or a Church-Strauss patient. And for those of you who don't know what a myringotomy is, anything in medicine oddity means to cut open. Tracheotomy, cut open the trachea. Myringotomy, that's Latin for the eardrum. Someone's had 3 openings in the eardrums. Most of us, when you open an eardrum, it'll heal within a day or 2, 3 days tops. That's why sometimes we put in something called tubes, which is like a little grommet through that hole, basically to keep this hole open. So, to answer this question on the simple level, usually if you're a Wegener's or a Church-Strauss patient, you're doing a myringotomy, unless it's for an acute issue, like you need to fly in a plane and you're congested, I would generally put a tube in. With all that said, Church-Strauss is probably worse for middle ear disease than Wegener's. The lining of the ear, again, think of Wegener's and Church-Strauss as primarily as a respiratory disease. I'll leave it to Doctors Monarch and Abdou, the kidney side of it. But there's a lining from the nose to the end of your lungs, your sinuses, that have respiratory lining. Well, guess what? The middle ear and the mastoid also has a respiratory lining. That's why Wegener's can attack the ear. I've seen more than one patient that their initial presenting sign of Wegener's granulomatosis was mastoid/middle ear disease. So in the context of the hearing, there are 2 sides to this question. Number 1, how do you deal with disease activity, diagnostic and or therapeutic? And the second side of this, the end result is what's your hearing acuity? At the end of the day, you want to hear, and if you don't hear or have problems, you can understand what a tremendous morbidity is. So with that preamble, let me just state, both Wegener's and Church-Strauss, when in doubt, put a tube in, suck out that fluid. It prevents mechanical hearing loss. It seems to prevent neural hearing loss. And we now have data, I've never published it, but I've actually seen neural hearing loss getting massively better over 1 to 4 months after the fluid is drained and the tube is put in place. Everything in medicine comes with a downside. What's the downside of tubes? Well, now the outer world now has exposure to this quote sterile middle ear. Probably not sterile anyway in the Wegener's Church-Strauss group, but swimming is an issue. Showering becomes an issue. Get a good pair of earplugs for $9.99 at the CVS or whatever the supermarket you have out here, and keep the ear dry, keep it ventilated. The air is good.
Couple questions. Before my Wegener's diagnosis, my right eye teared all the time. Now that the inflammation is controlled, my eyeball makes a popping sound sometimes just when I blink. It is not painful, but is it dangerous? I think this popping sound is probably air getting trapped underneath the upper lid. And sometimes if the eyeball would sink in the cavity a little bit, the upper eyelid doesn't maintain that very intimate position that it used to have, so that when you blink, you might trap a little bubble of air underneath there. And my guess is, especially when she says it's when I blink, my guess is it's trapping air. Someone suggested there might be a perforation in my sinuses. Occasionally, we'll see a communication between the eye socket and the sinuses. And perhaps the easiest way to diagnose that would be to plug your nose and blow. And if the air comes through, there's a connection between the nose and the sinus. I don't think that would be causing this popping sound, but we tend to see that in trauma, where you get a fracture, orbital fracture into the sinuses, and then sometimes with Wegener's, but the fistulas typically don't cause that. The other one, and I'm going to need the help of Dr. Minaj and Dr. Abdou on this one, but if one does not have a disease involvement in a particular organ at onset, is it likely to occur there in the future during a relapse? I don't think you can say, can you?
Yeah, I mean, it certainly happens. And so, there are a number of series that follow this sort of thing. I don't know the details in the eye, but for instance, the percentage of patients who have skin involvement at some point during the Wegener's is around 50%, and I think at disease onset it's typically quoted as somewhere between 10 and 15%. So that's an example. I can't quote the exact numbers, but these have been cataloged for all different organ systems. So I've got a number of questions related to medications and their side effects. So particularly cyclophosphamide, rituximab, and methotrexate, and I'll try to answer those questions in sort of a summary statement. So first of all, people are often rightly concerned about the long-term side effects of cyclophosphamide. The first thing I want to say with regard to that is that this is very well documented in Wegener's, and it mostly concerns people who were treated with daily oral cyclophosphamide for years. So the risks are thought to be far lower with the kind of regimens that we use now. Still, the more often that the longer you take it, the more times you need to take it, we think that risk goes up. But data that suggested that the risk of bladder cancer rose to as high as 10 or 15%, 10 or 15 years out after treatment, were patients who were literally treated for years with this drug, which we really don't do anymore. If you did get that treatment in the past, because it was standard of care when Gary Hoffman was working at the NIH, then you need to be monitored for that, whether you actually go directly to a cystoscopy to look in the bladder or merely have a urinalysis to make sure there's no blood. People differ on that. But that's something that needs to be considered. In a similar vein, lymphoma and leukemia, or a pre-leukemic condition called myelodysplastic syndrome, arose in a fair percentage of patients who got cyclophosphamide for a long time, but not so much those who didn't. The risk of infection is it's high. As has been referred to earlier in this session, one way around that is to have somebody who knows about the drug, who's checking your white blood count frequently and not letting it get too low. So part of that is a monitoring issue of checking the blood count rather than just the drug itself. Those are the main issues with cyclophosphamide. It can rarely cause other issues, but that happens more with chemotherapy. With rituximab, I think that what we really don't know about is the extent to which it's immune suppressive. And Dr. Spex was talking about this earlier. One of the things that I'll bring up, because it's in the news and it's a warning that appears on the drug label, so a particular rare infection in the brain called PML. And this is something that has been seen particularly in patients with lupus who were treated with rituximab. But it's also been seen in patients with lupus who were treated with other immune suppressive drugs. And it has been seen, as far as I know, not ever in a vasculitis patient yet, treated with rituximab, and rarely in patients with other diseases like rheumatoid arthritis. So this may be a particular dangerous infection that is associated with this drug, but it may not be. It may be due to immune suppression in general. But I think we have to remain alert to the possibility that this drug does, is still immune suppressive and may have unusual toxicity. The last thing I wanted to say, there were several questions about specific side effects of methotrexate, and all I want to say there is that it is helpful. It isn't always true, but it's helpful when you're trying to think about whether someone's having a side effect of methotrexate to see whether it correlates in time during the week with when you take it. So I've had patients who have had what do not appear on the label from methotrexate as side effects, such as dizziness, that clearly happened for 2 days every week after they took it, and then they were fine. Then it happened again, and when we stopped the drug, it went away. That's very common with things like fatigue. Some of the other side effects of methotrexate, like sores in the mouth, may not correlate so much in time, but that is one thing that's a clue to the drug being a cause. We can't always figure it out. The other thing I want to say about methotrexate side effects is a lot of them get better with increasing the folic acid therapy. This gets to a question that was brought up before. There was initially concern with the use of methotrexate in rheumatology that giving folic acid would actually be an antidote to methotrexate and it wouldn't work. And it turns out that that's not true. And the reason is because the mechanism of action of methotrexate in fighting inflammation is a little bit different than just competing with folic acid. And so we ramp up the doses pretty high. I initially start with 1 milligram in everybody. I increase it to 2 if they have side effects, and I use a drug called leucovorin weekly as a chaser the next day after methotrexate if that doesn't work. And the majority of patients actually have good controlled side effects. If there is a reduction in the effectiveness of methotrexate with that kind of strategy, it's really small. In rheumatoid arthritis, there's some studies that suggest there's no difference at all, and some that suggest that the difference is slight. So in general, we think that if methotrexate is otherwise a good drug for you, trying to control side effects with folic acid is a good idea.
I have a few questions here, rather simple. How often should blood work be done after a Wegener's patient is off medications? I assume off medication in disease remission. Again, it depends. There is no really strict guidelines, but I would do that 3 months times 2. Things are stable, good, no complaints, exam is okay, the ANCA is stable, the kidney, liver, lung, sinuses are stable. I say I would space that, and again, I cannot give you a rule. It depends on the patient. In my practice, I do 6 months, maybe after that a year, maybe yearly after that. So there's no strict guidelines. I always learn from my mentors from Mayo Clinic that every patient is different. You have to monitor that and adjust based on the patient. There is no strict guidelines. It's an art of medicine. Every patient is different. You have to tailor the workup and the treatment based on the patient. But these are general guidelines. If things are stable for a few months of the year, maybe yearly. And you need to educate yourself about what should you look for to be on alert if the disease comes back. As I mentioned earlier, decreased hearing, sinus drainage, blood in the drainage, coughing blood, coughing a lot, extremely weak, joint aches and pains, muscle joints, rash, all that are bad signals, things are coming back. So you need to educate yourself about that. Question here, what disease can you develop if you have chronic low white count? The disease is infections. White cells, like an army, for defenses. If you want to win a battle against infection, you need 100 soldiers. If you have 20, you're going to be defeated by the bugs or bacteria or viruses. It's as simple as that. So if you have chronic white cell count, you're going to develop infections. And find a way to raise your white count for defenses. More important, quality of that army. Not only quantity of that army is important to me. And they're now in immunology tests to test the quality of the white cells. Can they run? Can they eat? Can they grab? Can they digest? Can they tell or not? The beautiful tests now available, and ask your doctor to test not only the quantity, that means low white cell count, but is what's left in your blood good, strong, on alert, have guns, know how to shoot. That's important to me, equally important. We can live with half the number if they are on alert, have guns, know how to shoot, and not weak. So it depends. But there's no strict guidelines for that. Simple question, is IgA nephropathy related to Wegener's? The answer is no, as far as I know. Unless you have I don't think any connection between the two. I never have any specific, I don't have any specific instructions about diet for vasculitis. Is omega-3 of any value? I'm not aware of any value, but if you are eating well-balanced diet, 3 meals, I think that's all you need to do. I have to tell you, there is lots of commercial pressure. Lots of commercial pressure, money-making companies. So be careful about that, that's all I can tell you. But to my knowledge, unless my partners here have any suggestion about diet for vasculitis.
I won't comment on the diet part. I'll leave that to the real doctors, the immunologists, rheumatologists. Two related questions, I'll leave them both. Is there research that shows when a Wegener's patient has a septorhinoplasty to fix breathing issues when first diagnosed, and they have a greater chance of relapse, or the surgery will cause the disease to go out of remission? But I guess, as I understand that question, is can endonasal sinus surgery cause Wegener's to flare disease activity? And the next question related is if someone has surgery to correct a saddle nose deformity, can the new nose also develop a saddle nose? So these are interesting questions, and I'm going to combine the answers to the two. In terms of the second question of new nose, I'll start by saying medicine and surgery in particular are very humbling professions. We have what I call an immediate perioperative phase where you're at risk for complications for any procedure. But let's assume you get through the acute phase and everything's great, and we're talking about a year down the road, can this develop? And the answer is basically yes. I've had one patient who ended up with a beautiful nose, and about 2-3 years later her disease flared, and she lost about 50% of the reconstruction. Why is that? Let me now get into the other question. In and of themselves, the surgery does not trigger disease to the best of my knowledge. What it can do, if it's done, depending on how it's done, may trigger certain related complications. And the difference is not just theoretical. If you're doing any type of repair of the nose through an open approach, and this may sound bizarre what I'm about to say, you're not really in the nose. You're doing it from the outside of the nose by lifting up the skin, and hopefully you don't actually get into that respiratory or diseased tissue, and you repair whatever way you think is the right way. On the other hand, we alluded to this in one of our breakout sessions, if you're doing, as I say, a septorhinoplasty, where you're working on the nose bone for breathing issues, and that's a very legitimate thing. Trust me, you can't breathe your nose and stop. It's a miserable way to live. You can't smell it, you're at risk for infection. If you're going to do certain things as a doctor to strip what's called the lining off the cartilage, you're basically interfering with the blood supply. Now you're dealing with tissue that's already sick, inflamed, it's got this weird disease, it's got to come back and now provide blood to that cartilage. It doesn't always do that. So in that sense, you can have a direct consequence of the surgery to cause a collapse of the nose, to cause a saddle nose deformity. But that's a mechanical issue rather than actually the disease being triggered in an immunological sense. It's not something that you would go to Dr. Abdou or Dr. Monarch and say, you need Rituxan for that. That would be really a surgical complication. So that's why it's got to be done the right way, it's got to be done with a certain amount of understanding, and you need to sort of stratify what your immediate and delayed goals are. Another question here, during peak flu and cold season, many healthy people take herbal supplements or products like Emergen-C to boost immunity. Should a vasculitis patient who's being treated with an immunosuppressant avoid products like this? I'm just going to echo what Dr. Abdou said. A lot of these things are commercial enterprises, and in terms of what's called adjuvant therapy or immune system stimulants, as a general rule, I don't think we do that anymore. Years ago, there was something called BCG that people used to get, not really in the US, but you see in people who come from other countries. They get false positives a lot because it stimulates something called T cells. In the flu season, and I'm really going to echo what Dr. Abdou said, hygiene, common sense, stay away from people with sniffly noses, don't have people sneeze on you, and keep current on your immunizations, absolutely. I'm not convinced, certainly as far as I know, this is not FDA approved or encouraged to prevent flu-like symptoms, certainly in somebody with a chronic illness.
I just have one question. A patient wrote in and said that I have Sjogren's syndrome, dry type macular degeneration in my right eye, my punctal duct has been cauterized, but my eye is useless. Anything that can be done? Wegener's, for some unknown reason, can affect salivary glands. And that would be one of the mechanisms by which you could develop a dry mouth. Sjogren's syndrome is a dry eye and a dry mouth. The lacrimal gland is also a salivary gland, and that's why the lacrimal gland can be attacked in the same process. When we have a dry eye, there's kind of a stepwise process that we follow. The easiest thing to do would be to suggest some artificial tears to someone. An artificial tear is not an artificial tear is not an artificial tear. There are various types of artificial tears. For someone who needs artificial tears on a very frequent basis, you should probably buy the preservative-free artificial tears. If you are using them more than perhaps 4, 5, 6 times a day, and you have the regular ones that you buy on the store with the screw cap on them, those have preservative in them. And if you use them often enough, the usual preservative is thimerosal that's in there. And you can get sensitive to the thimerosal and then develop a red irritated eye as a consequence of becoming sensitive to the preservative. So for real frequent artificial tear users, get the preservative free. Those are the ones that come in the little unit doses that twist off the cap, and then you use it maybe for an hour or so, and then you have to get another one. Yes, they are more inconvenient to use. Yes, they are a little bit more expensive, but if you need them, you need them. The other drop that I would not use is a drop to get the red out. That's got a decongestant in there, and just as you would not use a nasal spray every day because it vasoconstricts your nose, you don't want to use the drops that get the red out every day for the same reason. Artificial tears come in various concentrations. The less viscous ones are very soothing, very comfortable. They'll blur your eye just as long as the drop is in there, and then your vision's good again. If you want to have one stick around longer, there's a drop called Celluvisc, and that's about the thickest artificial tear that you can get. It has the consistency almost of Caro syrup. And the advantage is it lasts longer. The disadvantage is you put it in and your vision's blurry for maybe a minute or so till you can blink some of it away. But if you get a drop, any more concentrated drop, then you're in an ointment. And if you put an ointment in there, of course it'll last longer, but then you can't see. The next step beyond artificial tears would probably be punctal plugs, what this person was talking about. The concept of cauterizing your puncta or putting in a punctal plug is to, just like putting in the plug in the bathtub. So if you've got a little drip, drip, drip coming from the faucet, since the drain is plugged, that means that the water that you do produce will stick around longer. So punctal plugs would be a reasonable second option. The third and fourth options might be to consider something on your glasses. If you wear glasses, you can have the optical shop put a moisture chamber on the glasses, and it functions like a little greenhouse. And it just creates a more humid environment, but more importantly, it keeps the wind and the air from coming across the side and drying out the front part of your eye. So moisture chambers are very helpful on your glasses. Lastly, we could do some eyelid surgery. It's called tarsorrhaphy, where you just put a pinch in the outside portion of the eye and it cuts down the exposed surface area of the globe. And sometimes that will help when nothing else will. And also just one comment about the dry type macular degeneration. That would be completely unrelated to the Wegeners or to the therapy. But that covers the tearing part, I think.
So I realized I didn't quite, with my summary, cover the medication side effects that were specifically requested. I think these will be of interest to a lot of people, so I want to go through them specifically. So one question is, while on methotrexate for frequent headaches, does it matter if you take Advil, Tylenol, or aspirin? So this is important for a couple of reasons. One is that if you look closely at the warnings related to methotrexate, one of them is, and we sometimes get called by pharmacists about this, is non-steroidal drugs, which includes ibuprofen, Advil, etc. This is not an issue for methotrexate the way we use it. That's for very high doses of methotrexate used in chemotherapy, and it has to do with the metabolism of the drug. So it's a non-issue. The second is Tylenol. So both methotrexate and Tylenol are potential liver toxins. The two have not been regarded as mixing poorly with each other. So I don't tell people, and I'm not aware that I should, but I don't tell people to take less Tylenol if they're on methotrexate, for example. What we do routinely counsel is little or no alcohol, and little or no depends on who you are. So in the US, it's very common for people to say you really shouldn't drink at all. Of course, that's the simplest and easiest thing to say. In Europe, they don't really do that so much, and there's just more of a culture of very moderate drinking it with meals, and so I think they're a little more comfortable with some. No one knows the answer, but in general, I like to feel that if I follow the liver function test very closely, then we're avoiding methotrexate toxicity regardless of what the patient's doing otherwise. But I generally counsel no more than a couple of drinks. With the meds, it doesn't matter. With rituximab, it seems like one person would feel like the questions regarding rituximab side effects weren't completely covered. So I definitely want to talk a little bit about that. Other than infection, and as I said, we really don't know what its role in infection is. We think it's less than cyclophosphamide, I think it's less than prednisone. The other main thing that happens with rituximab is infusion reactions. And these particularly can happen with the first dose. Historically, they could be quite dangerous. This is before the drug was well known when it was used in lymphoma. Now we use pre-medication. We actually use fairly high doses of corticosteroids, also antihistamines, things like that. And the rate of severe reactions has gone down. The rate of mild reactions is still fairly high, particularly with the first dose. Usually we don't have to stop the drug, but I actually just treated a patient where I'm going to give up on it and go to cyclophosphamide because of the severity of reaction early on. So that's the main issue with that drug, and it does, unlike a regular allergy, which is usually worse once you get it, if you get it again, for whatever reason with rituximab, the risk of having an infusion reaction or the severity of the reaction, if you have one, actually goes down with repeated treatment. So it's not a concern, when you get it 6 months or a year later. And the other list of reported side effects with this drug is quite low, and this is generally true with the biologics in general. Because they're based on antibodies, they're not, I don't think anyone's going to discover years from now that, it damages your liver or your kidneys or your nerves or anything gradually over time, which anything related to a chemotherapy drug, has that potential.
I learned all these sessions, many of you have private questions that you are shy of asking them. So we're going to allow the last 10 minutes. So we'll be sitting here. You can come if you want to have another question that you are not the one to ask in public. We'll be happy to answer that. And I really would like to thank Dr. Robert Lebovics, James Garrity, and Paul Monarch. I think we have a great session. I hope all your questions are answered.